Hello, and a very warm welcome to this event from all at FIND, the Global Alliance for Diagnostics, and the International Society for Neglected Tropical Diseases. One of the many opportunities to get together, take a moment to reflect, and most importantly, celebrate in this tremendous week for neglected tropical diseases. Indeed, this week will be, on the one hand, marking the 10th anniversary of the landmark London Declaration on NTDs and what heralded unprecedented support to this field. We'll also celebrate what is already the third World NTD Day, and beyond that, we can look forward to renewed focus and advocacy as the WHO's roadmap on NTDs to 2030 is implemented, and political commitment is renewed and further strengthened with the launch of the Kigali Declaration. So here we find ourselves at a significant inflection point in terms both of the understanding, the control, and in many cases, elimination of these historic diseases. And what has really underpinned these considerable efforts and achievements is a clear insight into the burden and the progress made, and all this carried through with appropriate diagnosis and therefore the right diagnostic tools. But gaps do remain, and so turning to the future and perhaps even the next decade in NTD control, today we'd like to take a closer look at how specifically bridging diagnostic gaps will be crucial, not just improving treatment and outcomes for those affected by NTDs, but will also be crucial in accelerating the goals of the public health agenda itself and further catalyzing political will and advocacy. So I'm sure that you will all join me in extending a very warm welcome to our 5 panelists today. Namely, I'd like to introduce and welcome very warmly Dr. Marta Fernandez-Soares, Chief Technology Officer at FIND. We're also joined by Dr. Dirk Engels, which I'm sure many of you will recognize as ex-director of NTDs at WHO and now senior advisor to Uniting to Combat NTDs. And in fact, Dr. Engels today will be stepping in for Toko Puli, Executive Director at Uniting. So thank you very much for that, Dr. Engels. We're also joined by Dr. Daniel Argo-Danye, Head of Prevention, Treatment and Care at the Department for the Control of NTDs at the World Health Organization. We'll hear from Dr. Laurent Fraisse, Research and Development Director at DNDi, and we'll also hear from Dr. Debbie Vermeij, all about the CUDA Chagas project based at the Oswaldo Cruz Foundation, Fiocruz in Brazil. So I'm sure that you're all joining me today to extend a very, very warm welcome to our speakers. Your participation as an audience, of course, is paramount and crucial. We would like everyone to be really involved and engaged. We can do so through the chat function. Please don't hesitate to give us your name, where you're tuning in from, and of course also ask any questions which may come about during the talks we will be hearing in a few moments. There is a Q&A function at the bottom of our screens. Please do go ahead and ask any questions or maybe share any experience or comments which you would like to. So we will be hearing some short presentations for our speakers, following which we'll have a discussion and a Q&A. But for the time being and without any further delay, I thank you once again all very warmly for joining us today. And I'll hand over to Dr. Marta Fernandez-Soares to open the session. Marta, over to you.
Thank you very much, Marianne. And good morning, good afternoon, and good evening. Thank you all for joining us today in this webinar, which we are delighted to co-host with ISNTD. I want to add my thanks to our keynote speaker and all of our panelists today for agreeing to share their thoughts and experiences with us in honor of the 3rd ever World NTD Day. As Marianne said, substantial progress has been made since 2012. As of 2021, 500 million fewer people need treatment for these debilitating diseases than in 2010. And 40 countries or areas have eliminated at least one of the 20 diseases that are currently in the WHO portfolio. However, not all of the 2020 targets were met. The updated 2030 roadmap pinpointed critical diagnostic gaps that have emerged as a key risk to diagnostic targets. Diagnostic testing is indeed central to safeguarding decades of progress in NTDs, and must be strategically leveraged to reach the 2030 global targets laid out in the NTD roadmap. During our panel today, we will hear how different organizations are working together to address this gap. We will hear about activities coordinated by WHO, including the establishment of the Diagnostic Technical Advisory Group, or DTAC. We will hear about FIND's activities on the need to increase accessibility to new and existing tools, as well as to establish open access resources to foster transparency and collaboration. And we will hear from the NDI and Fiocruz on the synergies between treatment and diagnostics to move closer to achieving the 2030 targets. There is a long road ahead, but the past 10 years have shown us what can be achieved when governments, industry, donors, and development actors share experiences and work together. Let us continue sharing and working together today through this panel. Thank you.
Thank you very much, Marta. And who better than Dr. Dirk Engels, with 20 years of experience at WHO itself, to start off our session today and give us a little bit of a broader context to the issues that we'll be discussing today. Dirk, over to you.
Thank you, Marianne. Can you hear me?
Very well, absolutely.
Thank you. As you already said, Marianne, this week on World NTD Day, we will be celebrating the 10th anniversary and the sunsetting of the London Declaration. That, in tandem with WHO's first NTD roadmap, has enabled unprecedented progress towards WHO's elimination targets and the NTD SDG target. We will also be launching the 100% committed movement and initiating the endorsement of the new country-led Kigali Declaration on Neglected Tropical Diseases. The successes we have witnessed over the last decade are primarily due to a highly committed public-private partnership that has been closely working with WHO and showing that ending NTDs is possible. You've all know some of the impressive progress that has been achieved as of 2012 onwards, but I would like to still highlight a few of the key achievements. 35 countries have eliminated one NTD, at least one NTD in the last decade, bringing the total to 43. There has been incredible further progress on guinea worm disease, with over the last year even an impressive decrease of the number of infections in animals. So letting us hope that we may achieve that goal soon. Over 13 billion treatments have been donated by the pharmaceutical companies and have been delivered to people, enabling over 1 billion people to be treated with an NTD treatment for 5 years in a row, from 2015 to 2019. And not only should we mention the medicine donations by the pharmaceutical sector as an example of public-private partnership, but we should also mention the product development partnerships that have managed to keep pace with the need to develop new tools in line with the requirements imposed by programmatic progress. A prime example of this is sleeping sickness, the first NTD to reach its 2020 target well ahead of time. All of this has been powered by an extraordinary partnership of dedicated and committed partners, united by a common goal of seeing the end to these diseases of poverty and promoting just and equitable healthcare for the 1.7 billion currently at risk of NTDs. WHO's new 2021-2030 NTD roadmap, launched just over a year ago, intends to build further on the principle underlying the progress to date and to further accelerate programmatic action for all 20 NTDs, highlighting in particular diagnostics, monitoring and evaluation, access and logistics, and advocacy and funding. This will inevitably imply enhanced product development, novel medicines, possibly vaccines, but surely novel diagnostics that are required across the NTD spectrum, whether it be for mapping or remapping, starting interventions for still some of the NTDs, changing intervention strategies for others, and stopping interventions and embarking on post-intervention surveillance for yet another group of NTDs. So that is really across the board. Even though the COVID pandemic has obscured the funding landscape for chronically endemic diseases, it may also provide opportunities for technological advancement, for the sharing of technologies, making economies of scale, and obtaining shorter timelines in diagnostic development. We cannot ask endemic countries to move towards enhanced ownership and domestically funded implementation if there is no parallel international effort to ensure availability and affordability of fit-for-purpose NTD medicines and diagnostics. This week, building on these previous successes and recognizing the changing global landscape, we are using World NTD Day as a catalyst to translate that awareness into action, to secure increased resources for neglected tropical diseases, and crucially, to facilitate political leadership and ownership of NTD programs by affected countries. By working together and across sectors in an integrated manner, we can and will achieve the targets in the WHO roadmap. These goals include 100 countries eliminating at least one NTD by 2030. It is actually this target of eliminating an NTD in 100 countries that has inspired the 100% committed movement. This movement will exist to connect people and amplify voices from endemic countries and especially from people affected by NTDs. Together we will call on governments, all those that have made the London Declaration so successful, but also new partners like parliamentarians, mayors and local government leaders, as well as continental and regional bodies and young leaders around the world, so that they are and remain 100% committed to ending NTDs. So what actually does it mean to be 100% committed? It means using your voices to champion the 1.7 billion people affected by NTDs who may not have a voice. It means sustaining and increasing commitments in the fight against NTDs. It means countries taking ownership of their programs by committing domestic resources. And it above all means endorsing the Kigali Declaration on NTDs, as you've all done for the London Declaration, and making the Kigali Declaration equally successful. I hope you will all be able to join us this Thursday to learn more about what needs to be done to end NTDs and to join the 100% committed movement. Thank you.
Thank you so much, Dirk. We will definitely be there. We will definitely put 100% in and join the events and also support the campaign throughout. There's been so much achievement under your tenure. It's been really inspiring. And so now we look forward to the next 10 years. And so at this point, I think it would be great to hand over to your former colleague, Dr. Daniel Argo, and I will just hand over to Daniel when your slides come up. As I said, you're head of prevention, treatment and care at the Department for the Control of NTDs at WHO. And we'll hear more about, on a technical level, how we're going to move towards addressing these diagnostic gaps.
Sorry. Thank you, Marianne, and thank you, the organizers, for inviting me to make this brief talk on diagnostics, the role of diagnostics, NTD roadmap, and how to address the issues around the diagnostic gaps. Pleased to talk after my former supervisor, Dirk Engels, who have eloquently addressed most of the issues around the diagnostics and set the scene about the week which we are right now started celebrating the World NTD Day for the first time after, especially after the endorsement of the day by the World Health Assembly. Okay. So the reassessment of diagnostics, during the development of the 2030 NTD roadmap identified a number of gaps and considered NTD diagnostics are critical gaps in order to achieve the new targets set by the 2030 NTD roadmap. Then the department, in collaboration with different partners, established this new diagnostics platform and mobilized support for development of priority diagnostics and to make diagnostics one of the central interventions or tools that are lacking and that needs to be addressed during this period of the roadmap implementation. So the creation of the WHO Diagnostic Technical Advisory Group was one of this critical step to facilitate the development of particularly target product profiles and to help the development of diagnostic tools. The WHO DTAG was established in 2019 around October, following the recommendation of the Strategic Advisory Group for NTDs. The DTAG have held 4 meetings to date and have passed important recommendations and have really achieved tremendous work with regard to diagnosis, which I will be talking later. During the assessment of the diagnostic gaps were identified for each of the 20 NTDs or NTD groups, and the priorities for addressing these gaps were also highlighted depending on the stage of the program. As you can see in the heat map assessment for diseases which are amenable for preventive chemotherapy, the diagnostic gaps were assessed around mapping, starting treatment, for stopping treatment, or for post-treatment surveillance. So in the majority of diseases, especially diagnostics were lacking for stopping treatment and post-treatment surveillance. However, depending on the diseases, some diseases even do not have good diagnostic tools for mapping and also for initiating treatment. For diseases amenable to case management or this so-called innovative disease management approach, the diagnostic gaps were identified in for screening, confirming diagnosis, individual diagnosis, and also for running surveillance systems. So as you see, the red color indicates the critical gap. And if we are to achieve, unless we address this diagnostic gaps, it is not possible to achieve the roadmap targets for those diseases where we see red colors. So then the priority diagnostic needs for each of these diseases were identified in the NTD roadmap. So what is the DTAG and what is its role? How is it structured to address its role? Basically, the WHO Technical Advisory Group for Diagnostics helps us to define priority gaps for diagnostics, and it helps us for the coordination of the development of target product profiles for priority use cases. So the DTAG also helps us in setting the priority use cases for each of the NTDs. And then it also helps us to provide position or policy statements around diagnostics and the availability of TPPs or identification of gaps is not enough. It helps us to also develop strategies to access whether it is already existing diagnostics or new diagnostics. The DTAG establishes ad hoc subgroups. These subgroups could be use case or disease or category specific subgroups, and they are established to deliver specific tasks. So as you can see here, so far around 6-8 disease specific subgroups have been established under the DTAG to develop to define specific use cases for each of the diseases, priority use cases, and also to develop the specific target product profiles in order to advise manufacturers and in order to advise donors to make investments for the development of these diagnostics. The DTAG has also 3 cross-cutting subgroups. The first one is the surveillance platform subgroup. This subgroup deals with the One Health, the diagnostic needs in order to promote and implement the One Health approach to NTDs, and the verification of elimination and post-elimination surveillance. So we believe that there is a possibility to combine a number of these activities if we have diagnostics that addresses these strategies. Then the second cross-cutting subgroup is the clinical diagnosis, imaging, and microscopy. And this subgroup is working on microscopy and image analysis, clinical examination, and also the use of advanced technology, especially the advanced technology in digital imaging and their application to neglected tropical diseases. The third one deals with the manufacturing and regulatory pathways. As part of the end-to-end approach, access could also be hampered by lack of manufacturing or lack of regulatory approval pathways. So this subgroup deals with important issues related to access to diagnosis, quality assurance, and regulatory pathways. Then we have a kind of subgroup to help all the work of the Diagnostic Technical Advisory Group and the WHO work on diagnostics, which is not directly reporting to the DTAG, but reporting to the department and working in collaboration with the department, is called the DTAG Informal Donor and Partner Subgroup. This subgroup is a time-limited informal group of funders and partners who are interested in supporting the diagnostics work through also supporting the product development. This subgroup really provides a strong support in analyzing the current funding landscape for diagnostics, and also helps WHO in fundraising strategy and to generate new resources for funding, and how to reduce also the funding gap and avoid duplication of funding through better coordination and possibility of co-funding for risk sharing and also risk mitigation among funders during the development of diagnostics. and also leveraging existing connection with the funding network for interventions by linking pipeline and funding considerations with existing therapeutics or prophylactic pipelines. So far, USAID, the GHIT, BMJF, and at the beginning, the FCDO UK was also part of this subgroup. It is open and it is promoting to include more donors and more members in order to support the work of the DTAG. So what has the DTAG has accomplished so far? The DTAG so far has produced over 10 target product profiles. 8 of these target product profiles have already been published. Despite the pandemic situation, the DTAG has worked intensively through virtual meetings and email communications to help produce this targeted product profiles for prioritized use cases that you see here. For LF, to stop triple therapy MDA, and also to help surveillance, and for onchocerciasis for mapping and surveillance, for schisto for monitoring, to help monitoring and evaluation and stopping or decision or surveillance, for STH for monitoring and evaluation. For human African trypanosomiasis, a test for rhodesian hat was prioritized and published, and a second one for Gambiense is in the process of publication. Then there is the skin NTD subgroup that is working on several skin NTDs. Almost all of these target product profiles currently are under development. They have completed their public consultation and are in the process of being reviewed for the comments received from the public, and some of them are under clearance, publication clearance process. So for Bruley ulcer, a rapid test for diagnosis at primary health care level, and for dermal leishmaniasis, a point of care diagnostic test for dermal leishmaniasis was identified, and for leprosy, a diagnostic test to guide post-exposure prophylaxis in leprosy contacts and high-risk groups, and also a diagnostic test to confirm the diagnosis of leprosy in individuals with clinical signs and symptoms to guide multi-drug treatment were identified. So also for mycetoma, scabies, and yos, the same public consultation for these target product profiles have been completed. Mycetoma, as you know, we don't have a diagnostic test right now. So it is, 2 types of use cases have been identified as priority: diagnostic tests that can differentiate EU mycetoma from actinomycetoma, and the diagnostic test to decide when treatment can be stopped. For scabies, a diagnostic test to start or stop mass drug administration. And for yos, a diagnostic test for detection of cases of yos, single infection or active infection of yos, and a diagnostic test for detection of azithromycin resistance have been prioritized. So, in summary, the 2030 NTD roadmap, as you all know by now, has 3 major pillars: the accelerate program actions, intensify cross-cutting approach, and changing the operating models and culture. We have also 3 the categories set in 3 category set of targets: the overarching, the cross-cutting, and the disease specific targets for achieving by the end of 2030. urgent need to develop accurate, reliable, and cost-effective diagnostics that are fit for the field deployment across all 20 NTDs at different stages of the program are really needed. Here, under Pillar 1, technical progress includes the scientific understanding and the presence of effective intervention tools, one of which is diagnostics. And for strategy and service delivery in the system, diagnostics are also important. So the same for integrated NTD on common platforms. So diagnostics are expected to support especially two of the three fundamental shifts of the roadmap, especially in measuring the impact. And also the second one is this cross-cutting, the enhancing the holistic approach, the cross-cutting and integrated approach. Can we have a diagnostic that can be deployed for integrated approach and for facilitating cross-cutting approaches in the NTD program? So in general, for currently available diagnostics, development of new diagnostics is one thing, but even for currently available diagnostics, access to diagnostics is an issue, quality of diagnostics is an issue, and local capacity for implementing diagnostics or for production are also critical issues that needs to be addressed during this period in order to achieve the 2030 NTD roadmap. So with that, I conclude my presentation. Thank you. Over to you, Maria.
Thank you, Daniel. It's been really useful to hear from yourself and also Dirk about both the wider framework and the mechanics and also strategies within WHO to improve the current diagnostic landscape and for so many diseases, and really impressive to hear all this output from the DTAG in what's been quite a short time frame really, and particularly with this ongoing focus on COVID-19. So that's been really useful. Thank you very much, both of you. And so now we felt it'd be very useful to turn to particular partners and organizations and hear a little bit more about their approaches based on what you've shared with us to increase the quality of diagnostics tools, but also, and all importantly, their efforts to increase collaboration in this field and ultimately, from the affected community's point of view, access to these tools. So as our next speaker, I'd like to invite Dr. Marta back to the stage, please. And Dr. Marta, you'll be sharing with us some of the work that's been ongoing at FIND in this field. Thank you very much.
Thank you, Marianne. And thank you, Daniel, for the clear and engaging presentation on the roadmap and the role of diagnostics. And a special thanks to all of you at WHO for your leadership. In this presentation, I would like to describe FIND's efforts to bridge the diagnostic gaps in NTDs following the roadmap, the 2030 roadmap as a guide to action. Before I delve deeper into the NTD program, I just wanted to give you a brief introduction to FIND. FIND, the Global Alliance for Diagnostics, seeks to ensure equitable access to reliable diagnosis around the world. We connect countries, communities, and other stakeholders to support diagnostic innovations and to make testing an integral part of sustainable resilient systems. FIND was established in 2003 as a product development and delivery partnership, or PDP. Since our funding, our strategy has evolved to expand the portfolio of diseases we cover, from our longest standing programs, which is neglected tropical diseases as well as tuberculosis, to now include pandemic threats, malaria and fever, AMR, hepatitis, as well as non-communicable diseases. The scope of activities has also broadened to ensure that we cover the entire value of diagnostic change, from R&D through clinical studies and to implementation studies, capacity building, and other access activities that allow diagnostics to be implemented into integrated approaches, as Daniel from the WHO was just highlighting. We're a co-convener of the diagnostics pillar of the Access to COVID Tools Accelerator, ACTE, and a WHO Collaborating Centers and HIVD member. Since its formation, we have been observers in the DTAC and also members of some of its subgroups. I'm not going to go very deep into this because Daniel has done a great job at describing the tremendous amount of collaborative work that went into developing the 2030 roadmap. So just to reiterate Daniel's message, diagnostics have emerged as a prerequisite to achieving the global targets. And as can be noted in this graph, 6 diseases, which are highlighted here in red, are still missing diagnostic tools. Whereas only 2 diseases, here highlighted in green, JAWS, as well as snake bite and venoming, are supported by adequate and accessible diagnostic tools. For the remaining 16 diseases in the roadmap, those highlighted here in orange, tools are available, but they may need to be either modified or adapted, or their accessibility may need to be improved in order to support reaching the targets. These NTD gaps have many root causes, such as the lack of data to guide interventions and investments, the fact that there are few development partners, there's no deliberate effort to establish an information mechanisms that can avoid duplication of efforts. And I'll talk a little bit today about how we're trying to tackle some of these, and as well as the fact that new treatments need improved diagnostic tools. We also know that many of the barriers to the development and delivery of the NTD diagnostic tools that existed before has been exacerbated in the last 2 years by the COVID-19 pandemic, which has wreaked havoc in the health systems worldwide, and particularly in low and middle income countries. COVID-19 impacts include interruptions to mass treatment campaigns for diseases controlled through preventive chemotherapy or individual case management interventions, as well as rerouting the already sparse available funding and resources. In addition, as we have discussed with many of our partners, the lack of sustained coordination also leads to the less efficient of scanned resources. Importantly, however, the new NTD roadmap offers a series of multi-sectoral actions and intensified cross-cutting approaches, as Daniel was highlighting, to get us back on track, with diagnostics being central to unlocking and accelerating the progress. For this reason, following the publication of the 2030 roadmap, we call on stakeholders to work together to create an ecosystem that prioritizes country-level action, where countries take ownership and integrate NTD diagnosis into the national health system health action plans, collaboration among the stakeholders, and commitments to new levels of visibility and transparency. As I will explain in the next few slides, we at FIND have proactively refocused our NTD strategy to include not only disease-specific projects, as we have done in past years, but also cross-cutting activities that aim to foster this transparency and visibility that we're calling for. Before I describe the cross-cutting activities, I want to quickly mention the 7 NTDs for which FIND has active or planning STAR projects. These are Buruli ulcer, Chagas disease, human African trypanosomiasis, schistosomiasis, visceral leishmaniasis. And then we also have 2 programs that are still in the planning stages, lymphatic filariasis, as well as onchocerciasis. On the left in this map, you can see that our active projects span partnerships across countries in Latin America, Africa, and Southeast Asia. For the 7 diseases that we have prioritized, we have identified gaps which span the whole diagnostics value chain, as we've been saying, from the creations of new tools, such as in the case of Buruli ulcers and schistosomiasis, where we're working with partners to develop and evaluate new diagnostic tests, through the clinical evaluation of currently existing tools, such as in our work as part of the Cuida Chagas consortium led by Fiocruz, where we plan to select the best performing rapid tests for congenital Chagas disease and to evaluate their potential impact as part of new control strategies. In this particular project will be further discussed later in this panel by Debbie Mermaid. In the case of African trypanosomiasis and visceral leishmaniasis, many of our activities are part of the Trypano collaboration, and the EDCTP grants are focused on access activities, including capacity building, with the goal of making existing tools more available and increasing testing rates, working towards elimination in the case of HAD and reduction in cases in the case of LASH. Finally, as I mentioned before, although we have not started yet, we're also planning to initiate exploratory activities to improve surveillance for lymphatic filariasis and onco. As I mentioned before, however, while each NTD has specific challenges, it is important that we work to addressing these. There are also clear common areas for actions that are common to all NTDs and that are equally important if we want to achieve the targets. These cross-cutting areas seek to maximize the use of existing resources, to reduce duplication of efforts, to connect the right stakeholders, and to increase efficiency. Firstly, I will describe the Virtual Biobank initiative, which seeks to source samples for test development and evaluation, and to provide information on who is collecting samples, the sample characteristics, where they are stored, and how to access them. This Virtual Biobank aims to address the long-standing issue of lack of transparency and equity in the collection, distribution, and use of human specimens. Next, I will describe the plans to develop a publicly available NTD diagnostic pipeline to provide a clear overview of what is already in the market, what is in development and their timelines, to map out the funders, and to identify and highlight gaps where further interventions may be needed. Very quickly, the DX Connect Virtual Biobank is an open access resource that provides a global view of aggregate data on sample collections from dispersed institutions, irrespective of where the samples are physically stored. This means that the Virtual Biobank is not a single collection of specimens held at a central location, but rather it means to connect and make available to everyone a decentralized network of collections stored worldwide. Through the DX Connect, we seek to connect institutions holding infectious disease samples, the sample providers, such as ministries of health, research institutions, hospitals, universities, laboratories, and other biobanks, with the researchers and organizations who need the samples to do the research to develop and validate diagnostic tests. Through this online portal, sample providers can register their collections, while sample requesters can search for samples to meet their needs. Here on the right, you can see a display of the search engine interface. The open access platform exhibits and helps to locate the samples from multiple repositories without registration or a use fee. Throughout the process, the institutions maintain full control over their samples and the terms of access. The Virtual Biobank already includes 7 collections with samples of Borrelia ulcer, schistosomiasis, HAT, and LAISH, and more collections are in progress. You can further explore the current collections and to register a new collection at this link, which you can also access from FindMain's website. We encourage you all and all institutions and researchers working in this field to make use of this resource. In addition to the open access Virtual Biobank, FIND is also developing an open access online portal mapping the NTD diagnostic products as well as funding landscape. This portal aims to provide visibility across the whole NTD diagnostics landscape, harmonizing multi-sectoral efforts and creating a robust information platform from which new collaborations, synergies, and innovations can grow. This portal will serve multiple purposes, including driving advocacy to address clinical product and funding gaps, as well as reducing the likelihood of duplication of efforts. We will soon be inviting industry, donors, and others to provide information to contribute to the mapping. Importantly, I would like to highlight that we're working closely with the WHO DTAC to harmonize efforts on this front. While the NTD diagnostic portal is still in development, I would like to show you a glimpse of the current COVID-19 test directory, which is the framework that we will be using for the NTD landscape. The COVID-19 test directory was launched within weeks of the pandemic being declared to provide transparent information on the complex testing landscape that emerged, and it currently lists 1,152 tests. What you're seeing in this image is a snap of the current interface, which is in continuous development. Here, you can see that the directory allows you to search and filter by type of tests, by region or country of manufacturer, by target analyte, by sample type, and others. You can find more information and explore the directory at this link. The NTD diagnostic portal is the first planned expansion and adaptation of this interface to accommodate other diseases. This is all I wanted to share with you today. To wrap up, I just want to reiterate that the diagnostic gaps for NTDs span the whole value chain, from the R&D of new tests to the accessibility of fit-for-purpose tests that already exist. Importantly, new tests must be designed with access in mind, and access activities for NTDs must be prioritized within national health action plans. Finally, collaboration and open access resources are critical to achieving the 2030 targets. At FIND, we believe that together we can move closest to achieving the 2030 global targets. Thank you.
Thank you very, very much, Marta. This is such impressive material, both the virtual biobank, but also the NTD diagnostics portal. Really, I think we can say one of its kind, and with the huge potential to overcoming some very real barriers in diagnostic development. So very exciting work and very exciting tools. Thank you for sharing that. And I'm sure there will be a huge amount of uptake and interest, not just in the audience, but around the world as this gets developed and shared more and more. So thank you. At this point, we felt it'd be really interesting to turn to the DNDi and hear a little bit more about their efforts as well to bring closer together the diagnostic side of NTDs as well as the treatment side, and all the time really keeping at the heart of it the access issue. So at this point, we'll hand over to Dr. Laurent Fraisse, Research and Development Director at DNDi, to shed a little bit more light about the programs and objectives at DNDi.
Good afternoon. My name is Laurent Fraisse. I'm the Director of R&D at DNDi, and I'm really sorry I could not directly join the panel due to other commitments. So first, I would like to thank the organizer, FIND and ISNTD, for providing me the opportunity to discuss about synergies between treatment and diagnostic approaches to solve R&D and access gap. This is a very interesting way to reflect about the health benefit we would like to provide to population exposed to neglected tropical disease. So in an ideal world, and as for every other disease, we would like to detect easily at individual level and without ambiguity the presence of the NTD infection. Treat with a clear aim to cure and be able to measure the benefit. In some cases, we also would like to use the treatment tool as part of disease elimination strategies. So both approaches are much more complicated or simply cannot be envisaged without the combination of use of effective, safe, easy to administer drugs and simple, sensitive and selective rapid diagnostic tests. Let me try to illustrate where we are and what synergy between diagnostic and drugs means with 3 examples of disease in which DNDi and partners are working together to develop solutions for patients. For Gambiense human African trypanosomiasis, 3 generations of treatments have been developed and a new one is emerging. We move from a very toxic injectable treatment to an expected oral, single dose and much safer one. However, today, patient identification remains dependent on an invasive and painful lumbar puncture and parasite confirmation. Although beyond relapse surveys in clinics, there was also no test of cure available to support development and shorten timelines. Other diagnostic tests based on nucleic acid detection are under evaluation, and several serological-based RDTs exist to support alternative strategies. So today, the fundamental evolution at treatment level creates new perspectives and allows the scientific community to develop new target product profile, not only for confirmed cases with the risk to exclude patients at early stage, patients at risk, or playing a reservoir role for the parasite, but, for example, extend the use to only suspected jihad patients, eventually even without parasitological confirmation, simply on the basis of a rapid diagnostic test. These changes will also rely on the quality and easiness of the available diagnostic tools. So with these transformations, Gambiense human African trypanosomiasis elimination is really in perspective. So for visceral leishmaniasis, current treatments are parenteral drugs with toxicity, which require hospitalization and with variable efficacy in the different endemic regions. So DNDi network is developing a new generation of drugs expected to deliver shorter, safer oral treatment. The currently available rapid diagnostic tests are based on antibody detection and do not perform very well in Eastern Africa, the area with the highest burden of visceral leishmaniasis. In addition, they have poor performance on the diagnosis of HIV VL co-infection patients and are not suitable for diagnosing relapses. For confirmatory diagnosis, patients still need today to have tissue aspirations. So the need here is the development of an integrated package of antigen-based point-of-care rapid diagnostic tests. This would allow reduced time between onset on symptom and treatment, reduce morbidity and mortality, and break the cycle of transmission. This would also allow rapid diagnosis of HIV-VL, PKDL patients. This could also become a tool to monitor treatment outcome and contribute to shorten development timelines for new drugs. So in this area, DNDi and FIND are working together within the EDCTP-VL INNO consortium for the development of drugs and antigen-based RDTs. Objective is to deliver a test and treat package that can be deployed in low-resource settings. Finally, for onchocerciasis, the approach proposed by DNDi and partners is transformative at therapeutic level. By targeting adult worm on top of microfilariacide activity, the objective is to develop a short oral and safe curative treatment. These new generation for macrofilaricidal drugs are currently at clinical proof of concept stage. If successful, this approach could fundamentally change the way onchocerciasis is managed in endemic areas, allowing, for example, individual curative treatment of case, supporting mass drug administration activities in hypoendemic or low-ASIS area, as an example. However, the only available direct assessment of infection today remains the skin snip, an old and invasive technique, although less sensitive in hypoendemic areas. The other diagnoses currently used are nodule palpation, rapid diagnostic test based on antibody detection, or vector assessment. So in order to make the best use of therapeutic innovations, a more sensitive and field-applicable diagnostic tool is needed, which would detect active infection rather than exposure to the parasite. So an antigen-based RDT will be a major asset for clinical trial evaluation and field use. DNDi together with FIND support this activity by setting up an in-country biobank with ANRB to have clearly defined samples to test such an approach. So to conclude, synergies between diagnostic and therapeutics in the development of treatment strategy for neglected tropical disease should not, in my sense, deliver only incremental improvement, but rather should serve fundamental, transformational, rapid changes, allowing access for neglected population to modern, individual curative treatment solutions and options for disease elimination. Collaborative effort will be key to achieve those goals. Thank you for your attention.
Well, a big thank you to Laurent, and I hope if you do watch the recording that you will hear this big thank you that we address to you and to the team at DNDi. Really interesting updates on quite a few NTDs there, but also really this reminder that the next phase in diagnostics development won't and shouldn't be incremental, but really has the potential to benefit from fundamental and really transformational approaches, particularly with digital approaches as outlined by Marta, but also by lots of other groups working on digital diagnostics out there. So some very inspiring work there. And finally, moving on to another neglected disease, we would like to invite Dr. Debbie Vermeij to come to the stage. Debbie will be talking about Chagas disease and particularly congenital Chagas disease and how diagnostics there would improve outcomes for mother and baby, but not just in a void, also as part of a wider treatment and also care package. So we look forward to hearing more from you right from the field. Thank you, Debbie, over to you.
Thank you very much. I am just trying to find my presentation. There we go. And this is not moving to the presentation mode. Let me try again.
If all else fails, we could see the slides quite clearly.
Yeah, unfortunately, it's not moving into presentation mode, but I can start not to waste any more time. So thank you very much for the invitation to speak a little bit on our project. I think our Our project is an example of where some of the topics that were mentioned by the other panelists come together. I would like to start with a little bit of an explanation on Chagas disease, because within the group of NTDs, it is really a neglected disease, and not everybody knows what Chagas disease is and what it's about. And it's not moving. Natalie, can you please share my presentation and go along with me? Thank you very much. And my apologies. So yeah, we can go to the next slide, please. So Chagas disease is a disease caused by a parasite called Trypanosoma cruzi, and its main forms of transmission are contact with the feces or urine of the infected triatomine bugs, also called kissing bugs, the consumption of contaminated food, blood or blood product transfusion, organ transplants, and transmission from an infected mother to a newborn during pregnancy or childbirth. Chagas disease has two phases, the acute and chronic phase. And next. And if untreated, an estimated 30 to 40% of people with Chagas disease will develop severe and sometimes life-threatening problems, mostly cardiac and intestinal problems. Next slide, please. Just to highlight some numbers, so the disease is mainly found in endemic areas of 21 Latin American countries. Next. An estimated 6 to 7 million people are infected with the parasite, and an estimated 65 million people are at risk of contracting the disease. Each year, an estimated 10,000 Chagas disease-related deaths are reported, and only an estimated 7% of people are diagnosed, and about 1% receive treatment for Chagas disease. So this clearly demonstrates the need for diagnosis and treatment and improvements in that area. Next slide, please. So there are a number of barriers that we have to face when it comes to Chagas disease. So there's a lack of verified data on the Chagas disease burden, and this is also demonstrated by the fact that the last official data that were published by WHO are from 2010. So there's not a lot of verified data out there, which makes it difficult to estimate what the exact burden is. Then there's the access to health facilities. One of the other barriers, you can just click on it and mention all of the barriers. So access to health facilities, as the disease often often targets the most vulnerable populations, their access to health facilities is limited due to geographical distance or other reasons, which doesn't help in eliminating this disease. The diagnostic process of Chagas disease is time-consuming, costly, and often very complex, and it requires lab-based diagnostic tests and for newborns, it's even more complex. The access to treatment is limited. There are two main treatments out there, benznidazole and nifortimox. Treatment periods are long, between 60 and 90 days. There are a number of side effects that can happen with both treatments, and medical doctors are often hesitant to prescribe the treatments if it's available at all. So access to treatment is really an important barrier. Then there are a lack of integrated actions regarding surveillance, control, and care at primary healthcare level. And this also is related to maternal and child health, where Chagas disease is not always integrated. So there's limited knowledge on Chagas disease, both by the general population as well as health professionals. And as mentioned, it affects mostly vulnerable populations, or disproportionately vulnerable populations. Next slide, please. So that's where our project comes in. The goal of our project is to contribute to the elimination of congenital transmission of Chagas disease by scaling up and enhancing access to diagnosis, treatment, and comprehensive care through innovative and sustainable approaches in Bolivia, Brazil, Colombia, and Paraguay. Next slide, please. So just to demonstrate the 4 countries, and the areas marked in red or pink are the different areas where the project will enter. Next slide, please. The project is made up of a consortium, an implementing consortium consisting of governmental and non-governmental organizations. So the organizations are mentioned here: Fiocruz, Fiotec in Brazil, INS in Colombia, Enlace via Cenepa, Paraguay, together with FIND. And we work together with a number of organizations, closely together with PAHO and WHO, civil society organizations represented through Fin de Chagas, and our partners, DNDi Latin America and NHR Brazil. Next slide, please. So the project includes 5 different outputs. The first is focused on evidence generated on effective test, treat, and care approaches through implementation research. The second output, community and civil society engaged at local, national, and regional levels to increase demand for services and advocate for integration of recommended approaches for Chagas disease in policies, strategies, and plans. Diagnostic algorithms validated for chronic and congenital Chagas disease, evidence generated on improved treatment options, and the final output is around market shaping to ensure equitable access to innovative products for Chagas disease. Next slide, please. So the project includes 3 main studies: the implementation research, where we'll go into 32 municipalities in the 4 countries and try to demonstrate that through the implementation of test, treat, and care interventions, we can increase access of vulnerable populations affected by Chagas disease to diagnosis, treatment, and care. And the aim is to develop different models, different implementation models that can be replicated in different scenarios in Latin America and beyond. The second study is a validation of a diagnostic algorithm that is based on rapid diagnostic tests. So currently there are rapid diagnostic tests out there, but they are not used frequently in any of the Latin American countries. So what we aim to do, there's evidence to suggest that by using 2 rapid diagnostic tests, 2 or more, you can correctly diagnose Chagas disease. Currently, the diagnostic process can take up to months because it's based on a laboratory test. So blood is collected, is sent to the laboratory. So before the diagnosis comes back, this may take weeks up to months, depending on the location where people are at. If we were able to validate a diagnostic algorithm, that would drastically shorten the time that is needed to diagnose people with Chagas disease. So the study will consist of different phases. It will be implemented in 3 of the 4 countries, namely Bolivia, Colombia, and Brazil, where in all of the 3 countries, a previous study was done to determine which are the best performing rapid diagnostic tests. The first phase of the study will include the identification of an algorithm, and the second phase will include the validation of said algorithm to see how it works in the field. Also because the reason why we're doing it countries is because the parasite has different forms. So there are different types of parasites, which means that we need to develop different algorithms to ensure that it works in different scenarios in Latin America. And then finally, there's a study where we will focus on treatment. Currently, as I mentioned, the treatment for Chagas disease is quite long. So we're focusing, benzimidazole is a treatment that is used often to treat Chagas disease, but the current treatment regimen is 60 days. So we are conducting a double-blind phase 3 clinical trial to evaluate whether a 15-day treatment would have positive responses as well, which would increase access to treatment on the long term. So these are our 3 main studies. What I didn't mention around the implementation research, which is important to mention here, some of the innovations that we're testing through the implementation research is, first of all, to use rapid diagnostic tests to screen patients for Chagas disease. So it won't be used, as we do not have a validated diagnostic algorithm yet. We will use the rapid diagnostic test to screen patients in the first instance. And if the rapid diagnostic test is positive, then it will go through the regular diagnostic process in the country. And in addition, for newborns, we will introduce PCR in the diagnostic algorithm. So currently for newborns, it's very difficult to diagnose. It takes a long time. A mother would have to come back with her baby a number of times for the baby to be tested. So we are introducing PCR into the diagnostic algorithm to shorten the diagnostic time, and therefore aiming to reduce the number of babies that kind of disappear along the process. So these are our 3 studies. Next slide, please. So overall, we are aiming in the 4 countries to screen over 200,000 people. As this is a project focusing on congenital Chagas disease, we are targeting women of childbearing age, their infants and their household contacts. Their household contacts might sound strange to people, but that is because not because Chagas disease is passed on between people in the same household necessarily, but the reason is if the woman has been infected, chances are that the people that live in the same household are infected as well, and we cannot leave them behind. So they will be invited for screening as well. So the total number is 234,000 people to be screened, which will hopefully lead to over 8,000 people treated with a number of benefits to both people and the health system to follow. The estimated results, the main estimated results of the study will be to have implementation models that may be replicated in different contexts, to have a diagnostic algorithm that will make use of RDTs, thereby shortening the time to diagnose a patient, and a shorter treatment regimen, thereby increasing treatment adherence. Next slide. So this was my presentation. I look forward to any questions that there may be. Thank you very much.
A very big thank you to you, Debbie, and thank you to all the speakers today. It's been over a very short amount of time, relatively. It's been incredible to hear about so many facets of diagnostics supporting the control and the understanding of NTDs, all the way from the high-level leadership at WHO, but also the mechanisms in place to deliver this vision, all the way to some groundbreaking digital tools, including a virtual biobank, and then down to the collaborative approaches led by diagnostics, supporting treatment, and ultimately aiming at overcoming those access issues. So all hugely important as we approach what some call the end game or the last mile, as many countries are seeing those elimination targets getting closer and closer. So it's been a hugely rich afternoon, and thank you very much to our speakers for your time today. Also, I'll take this opportunity to thank all the attendees, and in the spirit of World NTD Day, it's been lovely to see so many attendees tuning in from around the world. Just to name a few, we've had Chandrakant Ravankar tuning in from India, hello. Also Insaf Belhaj Ali from Institute Pasteur Tunisia, Anne Lodisot from Zanzibar, also Kyung-Yun Oh from the Republic of Korea, Enoch Boateng, having quite a nice time between the Czech University of Life Sciences in Prague and also the Noguchi Memorial Institute of Medical Research in Ghana, and many, many more. So thank you to all who came together today. We do have a little bit of time for a few questions. You've given us so much to think about and much food for thought today, dear speakers. So perhaps as our session kind of comes to a close and we try to really think about all these things, I wanted to kind of pick up on a question here by Carlos Teixeira. And Carlos was thinking about the virtual biobank platform and then just really using that to ask, there are, of course, so many issues to deal with, like different country regulations and so forth, issues around ethics clearance, international exchange of samples. I mean, these are just a few of the problems on a very practical sense of looking at the future of diagnostics development. And so perhaps if I can invite all the speakers to put their cameras back on, if that's okay, I might want to ask you, based on everything we've heard today, so what can the diagnostics and beyond that, perhaps the NTD community, since many of those are tuned in today, what can the diagnostics community do to further consolidate the multi-sector partnerships needed to bridge the diagnostics gap? In particular, are there partners you'd like to see more involved in this effort? And I suppose, coming back to Carlos's question, to tackle those very concrete and really present problems, very practical problems. Perhaps I'll start with you, Marta.
Great, thanks, Marianne. And thank you all for the questions. As I mentioned during my opening remarks, I think governments and industry, donors, development actors, we all must share experiences and work together if we really are to achieve the targets. I think specifically, I would like to make a call to action from the governments of the countries where the priority diseases are endemic. I think that as we enter this next decade of NTD activities, we need to shift from donor-led models to really country-driven initiatives. The ministries of health must engage and really advocate on behalf of their own vulnerable populations. And they need to ensure that the funded national health action plans prioritize diagnostics for NTDs. I think it is also important that we develop frameworks to enable industry, manufacturers, as well as pharmaceutical companies to engage in the whole process, not just in R&D, but all the way from R&D to supply chain logistics to really making these tools accessible. We understand that these are markets that are sometimes difficult for them, and this is why I think we need to just work together to create this framework to just really engage with industry. Thanks.
Wonderful. Thank you for your answer, Marta. And before I go over to WHO, perhaps Debbie, if you had any insights based on your work in field.
Well, I would have to agree with Marta that the involvement of governments is very important, but also civil society organizations need to be involved more. So we can talk a lot about the people that we're aiming to help, but we need to include the people that are affected by the diseases as well in all of our efforts that we do, because they are very much capable to speak for themselves and what they need. So it would be good to, and I know this is talked about a lot in different fora, but if you see the practice, it's quite limited still. So civil society, I would say, is another very important actor.
But interestingly, particularly in context of Chagas, it feels like the patient voice has really been supported, particularly in recent times, or it's kind of growing. So that's kind of very positive to hear.
It's definitely growing, but Chagas disease civil society is not as developed as as civil society for some of the other diseases. So we definitely have a lot of work to be done there, but we're moving. We're getting there slowly.
Brilliant. And so turning to Daniel and Dirk, and with your WHO perspective, and of course your remit being to bring so many countries and so many different types of partners, what do you feel you'd like to see more of?
Thank you, Marianne. Yeah, I agree with both Marta and Debbie. Really, we need to see government as donor partners or international community, and manufacturers and also other private sectors really to work together to address this issue. Coming to governments, it's really becoming critical and even more important because especially for NTDs, as you know, as we achieve the elimination and eradication targets, and the number of cases are getting lower, the volume required of the diagnostics is getting much smaller and smaller. This does not attract markets, the private markets. So the current model where diagnostics are left for development only by manufacturers is not working, is not going to be sustainable. So building local manufacturing capacity for locally endemic diseases is really critical and is really important going forward. However, this does not mean the need to put some seed money for development of diagnostics and building local capacity is not needed. This is really important. In addition to this, different models, the one working for drugs, like the product development partnership ships, which are very effective as the DDI, MMV, PATH. Of course, FIND is also working for the diagnosis, but this kind of arrangements and de-risking investments upfront for diagnostics development and deployment is really important. I think this is what I would say. I would add to what my colleagues said.
Wonderful, thank you. Dirk, what would be your thoughts on this?
I think for me, what is really missing, and I wouldn't say missing, it all goes in that sense. We heard today about a lot of collaboration between actors on diagnostics development. I think the same is also true for development of other tools and other products, but there need to be much more of that. I mean, for me, it still remains fairly fragmentary, fairly case by case, and fairly disease by disease. You can't avoid that, I agree. But I still believe there should be more sharing. It should be a much more comprehensive approach, both to diagnostic development and access, and access to new treatments or other tools. So, and if there's one thing that the COVID pandemic has learned us, is that with some will and adequate funding, that is possible. So it's just a lack of resources that is hampering that, I believe. So yes, there should be more country involvement as well. And I still remain convinced, and looking back at my long field experience, that implementation is possible and that countries can take charge of implementation. It is not, and it won't ruin them, but there needs to be this global international solidarity and to provide access to what countries need at an affordable price to implement.
Mm-hmm. Wonderful. And perhaps with the COVID pandemic, although we're not there yet, but we're edging towards better international cooperation on these issues. That's been really interesting. Thank you. And I think one gap that Adebiyi Adeniran has picked up on here in the Q&A, Adebiyi writes that technical capacity is a big challenge with NTD diagnostics. Programs in countries still don't have adequate technical know-how of existing diagnostics. And so I was wondering what you all felt about building capacity and some of these issues. Perhaps, Dirk, we could continue with you.
Say that again, sorry.
Oh, sorry.
Yeah.
There was a question here, or more of a comment by a colleague, Adebiyi Adeniran, who says that technical capacity is a big challenge with NTD diagnostics, even with existing diagnostics. So perhaps having more of having more of the approved proficiency testing panel of diagnostics for local labs and supporting programs with this. So perhaps more support for labs in endemic areas with the existing diagnostics.
Yeah, of course. I mean, even the existing diagnostics like a keto-CATS test is not that evident, you know, but that is all part of capacity building that has to become part of the routine, you know, education, training, and academic education in endemic countries. Now, in developing new tools, yes, you always have to keep in mind two things. They will have to be used in the field, so they have to be appropriate to be used in the field, even though technicity and technologies are spreading more widely into the periphery. That is, we can't avoid that. And access, you have to think of it from the start, as it has been said in the presentations. I mean, there's no point in developing a sophisticated diagnostic that is almost perfect and that can't be used in the periphery, and people have no access to it. So that is all part of the planning and of the target product profile, yes.
Wonderful. Well, at least we're all experts in lateral flow tests now, so that's one thing.
Well, another advantage, yes.
Would any of the other panelists like to add any comments to this in terms of capacity building, training with existing diagnostics?
Probably, Marianne, if you allow me, just to give also the information. Yes, this is really one of the critical gaps in many countries. Definitely, country programs needs to be supported to develop the local capacities. So WHO now is developing various online trainings which can be accessed from anywhere, free of charge, and it has its own assessment and accreditation. You know, we are using the WHO open platform, which was initially developed for emergency purposes, but they have kindly offered that platform for NTDs. It has over 5 million enrolled, you know, people for different courses, not only for NTDs. Over you know, there are courses over 50 languages. So far we've put several NTD materials, training materials across the range of diseases, and interested people can enroll and take the training. So in future we will be including more materials, including video, you know, clips materials, to show different procedures, diagnostics procedures, and people can train themselves.
Wonderful. We'll be looking those up. Thank you for sharing that, Daniel. Marta, if perhaps I could turn to you, and as we're running into the last few minutes of the session, maybe if you want to combine any of your thoughts with some concluding remarks on, from your vantage point, what in an ideal world would you like to see in the next 5 or 10 years when it comes to NTD diagnostics?
Okay, we're talking about the ideal world here, right, Marianne? Yeah. Which is the one we're all working towards.
Let's aim high.
Exactly. Well, so I think first and foremost, I would just like us to be working together to reach the global 2030 targets. I think for those diseases that are controlled through individual case management interventions, I would like to see a world where everyone who needs a test gets one, and is also empowered and trained, as we just discussed, to use it and to make decisions that will positively impact their own health or the health of their patients or their peers. For diseases that are controlled through preventive chemotherapy, I would like to see programs that are well coordinated, that are empowered with diagnostic tools that are appropriate to their needs, to enable accurate monitoring and evaluation, as well as surveillance. I think in the context of surveillance, this is something that has come up often. On the R&D front, I would like to see tools that are sensitive and specific enough to support the identification of cases in areas that are near or that have reached elimination. I hope it's not too much to ask.
Never. That's a really great note to end on. And perhaps the same question to Debbie from your vantage point of Chagas disease. What would you like to see in the next 5 to 10 years?
Yeah, what I would like to see for Chagas disease, I would like to see a number of the processes that we have in diagnosing and treating patients improved. I would like to see more attention to Chagas disease, better integrated programs in many of the countries, and especially when we talk about congenital Chagas disease, that it really that this really becomes a focus, because the vector control that has received a lot of focus in past years in many of the countries where Chagas disease is endemic. But congenital transmission, if we don't address this properly, it means that this can go on for many more years. New babies being born already infected with Chagas disease. So I hope we can contribute with our project to develop implementation models that can be used by governments in countries to help control congenital transmission and eventually eliminate the disease. So that would be my hope.
Sorry, and Daniel, just in a few seconds as our session draws to a close.
Yeah, sorry, is there any other specific question for me?
Yeah, just given your leadership and setting up and the growth of the DTAG, where would you like to be in 5 years from now?
Oh,
in a few seconds.
Okay, yeah, well, definitely 5 years is not a very long time with regard to development of products, So, but anyway, we're not starting from scratch. There are a number of diagnostics in the pipeline. So I wish those diagnostics to come into, final fruition, and I also at the same time currently available diagnostics, but which are not accessed by so many due to various reasons, regulatory or price or whatever barriers, different barriers. I wish they can be accessed to those the needy, so that we can really achieve by in 5 years it would be the mid-year for the 2030 targets, so we can achieve at least the mid-year targets and goals of the roadmap.
Fantastic. And Dirk, from your vantage point and your vast experience.
Yeah, I just hope that, well, first of all, in 5 years' time, I hope I will still be around. That's the first. And but then where would we be? I hope that the COVID pandemic is not going to set NTDs too much back, and that the NTD programs in countries will pick up. There are signs of resilience and that we build good resilience, but I mean, resilience has its limits as well. I mean, the means have to be there, and that we're going to continue with this global drug supply, that there will be access to new products, and I don't necessarily say they will have to be free, but affordable, and that countries can absorb them to use them for implementation. So, and that overall NTDs regains its rightful place in the global health agenda, as important as all the other diseases, maybe a more limited public, the poorer people, pockets of endemicity, so local priorities, not necessarily everybody gets it, no. So, but that it gains its and keeps its rightful place in the global health agenda.
That's a very good way to frame it, and really happy and excited to see the roadmap on the agenda of the executive board at WHO that will be meeting in a few weeks. And so, and combined with the 100% committed campaign about to be launched this week, and so many monuments lighting up around the world later on this week as well. So it looks like we're on the right path. And this is only the beginning of a very vast and broad conversation. So we look forward to catching up with you in the future and following all your projects and engaging with in the many ways possible. But in the meantime, I'd like to thank all our panelists once again for sharing so many insights across this last hour and a half. Thank you too to everyone who tuned in from around the world. I'd like to invite you now all to go and get a hot drink. And if you have a few more minutes to hop over on the other Zoom link, join us for an ISNTD Cafe Connect. It's a completely informal session where we'll just be sharing what's been happening in our different lives from our different perspectives in the last 10 years, and also looking to the next decade. What are we hoping for? All this just in the name of to celebrate and raise a hot drink, a glass to, well, the third World NTD Day. There are many things we couldn't cover today yet, and by all means, we invite all of you to get in touch with Find Diagnostics or with myself at ISNTD. If you still have questions for our panelists, then we'll be sure to relay those. So do get in touch. And in the meantime, I wish you all the best. Keep safe, everybody. And thank you once again for tuning in today. It's been a pleasure.
Thank you.
Thank you.
Thank you.
Thank you, everybody.
Bye.
Yep. All the best. Bye.